Good morning, everyone. Thanks for joining us. I have the honor and pleasure to introduce Dr. Brenda Gallie to you today, who will be our speaker. Dr. Gallie is a professor in the Department of Ophthalmology and Vision Sciences and in IMS at the University of Toronto. She's currently head of Health Informatics Technology at Techna Institute at UHN, a member for the Center for Global eHealth Innovation at UHN, and she's active staff at Sick Kids Hospital and Alberta Children's Hospital as an ophthalmologist. And prior to that, Dr. Gallie has held senior scientist positions at Princess Margaret and at Sick Kids Research Institute. For those of you who don't know, Brenda has had a long standing connection with this place, with the Vision Research Group. She was the first scientific director of the Eye Research Institute in Canada. So that was the first kind of iteration of the Vision program here at the Toronto Western Hospital. And to all of you who get the generous support for the VSRP, Brenda actually started the Vision Science Research Program. So we really owe her a shout out for that, because that's a really unique program that we are all very enriched by for trainees. But on the research and clinical care front, she's had a long-standing interest in genetics and understanding what is, as she was telling us in our chat before, the only inherited cancer, retinoblastoma. So her career has built on understanding the genetics of RB, and she was one of the first groups to identify the RB locus and to clone the gene retinoblastoma RB1, which was the first tumor suppressor gene identified. And at the time, that was a real paradigm shift in the way people thought about cancer. That, it wasn't just the gain of oncogenes, but it was the loss of tumor suppressor genes. And that RB1 was affected in not just retinoblastoma, which is a pediatric eye tumor, but in almost every cancer in the body. Although the inherited form of RB loss manifests at first in the eye. And she's had a long-standing interest in clinical care for patients with RB. I think initially when kids presented with RB, almost always the outcome was a nucleation. And with Brenda's work and activity in that area, the outlook is vastly different today. So I should also point out, you should read her CV. It's pretty amazing and daunting. But I can point out a few things that she's had a lot of recognitions for her contributions, not just research prizes. I think the one I picked up was the Helen Keller Prize for Vision Research for identifying the RB1 tumor suppressor gene, but also, more broad recognition, national recognition, and provincial recognition in the Order of Ontario, and she's a member of the Order of Canada. And I think that really highlights the impact Brenda's had in this area, and how it ripples out into a bigger understanding of how cancer develops, which is groundbreaking work. And today she's going to talk to us about her efforts on global health initiatives related to retinoblastoma, as well as, I think, new treatment approaches. So I hope I have that all correct, Brenda. And we're already sharing your screen, so I'm really looking forward to your talk.
Well, thanks very much, Valerie. I have to correct you. First of all, I did not get the RB1 gene, but the Helen Keller Award had 5 of us together on that award because everyone played a part, and my role was building up to clone it, and I was doing a sabbatical in Andy Becker's lab, and we were working towards that, but we did not achieve it. In fact, it was Ted Dreija is the real leader of that, who is an ophthalmologist in Harvard, and he was the one that did the first brilliant experiment. And you can read about all of that. That was published by Jesse Berry as a quite beautiful paper that describes everything we talked about in that Helen Keller Award. So I'd recommend you go and look at that paper, and it describes the RB1 gene. But I won't go more on to that. I have all these organizations, particularly the charities I'll focus, the International Retinoblastoma Consortium, the Eye Cancer Foundation, the After the Glow, Guerin Family Center, and Uplifting Athletes. These have supported the clinical trial I'll come to, and these have supported everything else we're doing here that I'll be talking about. And they're very dedicated people who work hard to raise that money, and we really appreciate it. So I'm going to talk about Canadian global leadership, but I have, why wasn't that working? There, click. The learning objectives are in bold. Retinoblastoma is complex. Point of care is the beginning of data. Precision care can be achieved by prenatal genetics for those H1 babies and optical coherence tomography. STEP RB clinical trial is very exciting. And most importantly, the Canadian Retinoblastoma Research Advisory Board of persons with lived experience, led by persons with lived experience. I'll first talk about Depict Health. The precursor of this is what is called eCancer Care RB. And since 2003, every patient in sick kids that has an examination under anesthetic and needs retinal drawings are done in eCancer Care RB. That's the predecessor for this new program. This is running only as a demo right now, but it's very close with the work in TECNA and other organizations, and now under the control of the charity International Retinoblastoma Consortium that licensed this Depict Health technology from TECNA, from the UHN. And this is getting ready to go global. You can go and log in here. Please record this, take a photograph, do whatever you need to get to this URL. But Safari or whatever will warn you you have an expired certificate. Don't worry, this is a demo. You'll see some real patient data on it who are consented by inference, by emails, et cetera. It's not official. And so just bypass all those things and say you don't mind the risk and go and look at it yourself. This is this is the baseline timeline of the home page, so to speak, of Depict Health. And you can see there's a lot of information here. These are real dates, real times. If you point to them in the live version, which I'd love to do, but it might crash. I'd love to do that with any of you. I can teach you anything how to use it live, but not here. What it does is lead you to the real date. These symbols are chemotherapy. This is the genetic testing, et cetera, focal therapies, intraarterial chemo, and enucleation. But up here is the 8th edition cancer staging, which is the staging of tumor. The primary tumor is T2A in the worst eye. The other eye, the better eye, is T1B. So this eye drives the staging because other cancer stagings don't have two tumors identified or more than one organ identified, unlike retinoblastoma. And no nodes, no metastasis, but H1 means they carry the RB1 gene. And then you can tab along and look at different things and see it. So this is an example of the retinal drawings that are in Depict Health. Retinal surgeons and people doing ophthalmology know about retinal drawings, but they were really most used in cancer of the eye, because what you see here is exactly the template with the ora serrata here, the mid periphery here, the optic nerve here, and this is covered up, but there's a little X there on the drawing for the fovea. And those were developed in the 1950s when the indirect ophthalmoscope was developed, and then they could realize that they didn't need to just look with a direct and recognize there was cancer in the eye, but that they could see the whole retina and then find all the different cancers. So we've taken those exact template and put it into the database and draw with the same color codes that have been used since the 1950s. Tumor is yellow. It's actually not yellow. It's quite white most of the time. And we distinguish it from Coats disease because Coats disease is more yellow. But conventionally, tumor has always been colored yellow. So we do that. Retinal detachment, for example, is blue. And if it got better, that would go away in the drawings. You draw this all online. And then you'd go to different things. Under diagnosis, you get to doing the staging, where we don't ask anybody to remember the staging. They put in the features of the eye and the computer stages it. So that reduces a lot of error in cancer staging. Another tab is images. So we do put images up. And this is the same patient that we just looked at here. So you can see by clicking on one of these images, we can see all the, this huge tumor. There's the optic nerve. This is the left eye that we're seeing here, and a smaller tumor out here, big juicy vessels feeding that tumor. So if you just look here with the indirect ophthalmoscope, you'd say, there's a tumor that vessel's feeding. And all of this goes into interpretation for retinoblastoma. So you can see this is the same eye. We'll just jump back. Wait, maybe I can't jump back. Yes, I can. So this is the eye that's drawn, and this is the image of that tube here. So the accuracy of the drawings gets better and better with the artist and the fellows who do it, but it's quite straightforward, and they all do it in the old drawing tool in eCancer Care every time you see patients and sick kids. So Depict Health is more than just the drawings and the clinical coordination. The data that's entered is by all of the people involved in the care team of the retinoblastoma patient, but includes that they will have read-write access to edit the database. And the institution like Sick Kids or Alberta Children's or the Ghana Hospital in Africa that logs in and joins Depict Health, they will see all those people will be able to edit their own patients. However, view access to the same data the patient family to coordinate. So the patient and legal parents can invite to that their family doctor, pediatrician, or anyone they want, like grandparents or anybody, and they control that access for those people. So that means the circle of care now becomes more than these clinical specialists, becomes the whole people who really are looking after the children. And Depict Health becomes like a checklist because the clinicians have things to fill out and are jogged to do that. They don't have to do everything. They can pick what's relevant for that event, but they're just kind of reminded by Depict Health. Depict Health is not custodian of any of the data from an individual site, treatment site. They are a service in communication for the site to sign on to. That's how it's defined. And we're just about finished our privacy impact assessment for authorizing Depict Health to run in US, Europe, and England, who have rigorous rules, which really are just different words used for different things. And that's going to be complete very soon. So here's an example of a child. Here's the timeline of a bilateral retinoblastoma patient. This was a previous version where we didn't put the lesser involved eye, but both of these eyes are T2B, which tells you it's a big tumor. This is not the picture or the drawing at diagnosis, but after 7 cycles of systemic chemotherapy and a nucleation of the left eye because it had poor vision. So there was no point continuing with that eye that had tumor that might be threatening the optic nerve. So it was enucleated. 2 more cycles of intraarterial were given to try to control tumor in this eye, but when there were more than 30 tiny tumors everywhere, we were really stumped. This was a good seeing eye. You can see now a new retinal detachment has come over top of the fovea, reducing vision, but before that it was a 20/20 fovea. And so we were desperate to do something but other than taking out his eye, but all the things we knew about it tried other than external beam radiation, which we don't do anymore unless we're desperate, were not possible. So I met Lynn Murphy, who had worked for years on a way to deliver chemotherapy to the eye only. And then one of his brilliant fellows had gone off and invented the chemo plaque. And so we put in a chemo plaque, which is our name for it. I'll tell you more about it in a few minutes. And at 12 days, all these had disappeared, including on the other side of the eye. Put the chemo plaque about here, but it diffuses through the whole eye. And the only remaining tumor that still looked active was here. And at the time it was removed, that we lasered that and did some things to it. But ultimately, we failed to control the tumor coming out of calcium, and that's being one of our biggest problems. The chemo plaque, the drug doesn't penetrate the calcium, maybe. But now with many other treatments, including more intraarterial and other unique things that have only been done in China and Toronto, removing tumor. We removed his calcium. He now has a stable eye, and he's now 3.5 years since the beginning of the chemo plaque with 20/50 vision, which is pretty fantastic for this little kid. This is a picture, recent picture at the last visit, showing his little bit of calcium remaining there and a fovea right there. So that leads me to describing the phase 1 clinical trial that had really been put together as a full protocol, REB approved in Children's Hospital LA, but no patient had ever been entered because they couldn't come to agreements with the company, 3T Ophthalmics, which is really two scientists building this amazing tool. And the American institutions who tried to join in, their hospitals insisted that they have a lot of money to run a clinical trial from the company. I said, no, we won't do that. We'll be the sponsor. So Sick Kids is the sponsor of this investigator-initiated trial. And the patient I just showed you is the very first patient. This patient is the first patient to ever receive that, not on the clinical trial, but with special access from Health Canada. And you can see it did a fantastic job. We did 3 more with special access, and then Health Canada said, no more, you have to run a clinical trial. So this is the clinical trial. I'm privileged to have fantastic co-investigators. Daniel Morgenstein is the head of the phase 1 clinical trial unit at Sick Kids. I've never done a clinical trial before. I took part in Helen Chan's international clinical trial, I'll mention later, but I've never initiated one. And I went into molecular science because the answers were kind of black and white, and it seemed to me clinical trials always needed a lot of statistics to make any point. So I went where it was easier. Ashwin Patna is now on staff at Sick Kids. He trained 11 years ago at Sick Kids in the fellowship program. Stephanie Kletke did her retinoblastoma fellowship a year ago and is now fully on staff. And Furkan Sheikh is the oncologist who is amazing with the children and amazing part of this whole protocol. So this is the chemo plaque at the time we're putting it in. So the study invention is week 0, when the chemo plaque loaded with topotecan, either 0.6 milligrams or 0.9 milligrams. There only are 2 sizes of the thing with different doses. It's a little tiny silicone device, and I have one right here beside me, but I will show it to you later if you want to see the real thing. It's about the size of your baby fingernail. And this is IV cannula, flexible cannula loaded with crazy glue, but of course we have to call it tissue adhesive because it's colored and it's for surgical use, so it costs about 100 or 200 times more than crazy glue, but it's the same stuff as crazy glue. You put it in a little T-shaped groove here, you place it, here's the panel, and the glue is right there. You put it between, here's the cornea, between silk sutures around rectus muscles, but no needles anywhere near an eye with active retinoblastoma in it. And it's placed back so that the front edge of it lies just between the 2 rectus muscles, the inferior and lateral, or inferior and medial. We prefer to put it inferiorly. I'll tell you why a little later. And we hold it for 3 minutes with this edited nice Wexel sponge with the tip cut off. It's very important. It kind of pushes it into place and holds it there for 3 minutes. And then we put in 2 sutures and close the conjunctiva over it all. And that's the end of it. It takes about 25 minutes to put it in. The study is escalating from 0.6 to 0.9 to 1.2. And we're now at 1.2 milligrams. And to achieve that, we put in 2 0.6s inferiorly in the 2 quadrants. And we will go sometime soon to the next dose level, at which point we'll put in a 0.6 and a 0.9, and then the highest dose level, 0.9. I don't know that we'll achieve this. I'll tell you a little bit later about that. We might end sooner than that. So it's a phase 1 dose escalation, single center, single arm, non-randomized, unblinded. That doesn't mean some patients might not be blind even before we start, but it's week 0 is when we put in the chemoplaque. First patient we left in about 70 days, the chemoplaque, but now on the study we leave it in 52 days because the rabbit model says the drug's kind of gone by 50. So we went back to 42 so that the amount of uptake from different devices and different patients would be more constant at 42 days. And so we take it out and we monitor the toxicity is recorded for up till 9 weeks, an additional 21 days. And we follow up for 3 years. All the patients on the study right now are in the follow-up period. This is the data of cohort 1, which is the 0.6, and cohort 2 and cohort 3 with 1 patient on it yet, and but 1 fully followed. So they're all very good initial response. 2 patients had progressive disease and were treated quickly, 1 at 5 weeks when that was obvious, and 1 at 7 weeks after in other words, we didn't complete the whole 9-week follow-up because when we took the chemoplaque out, it was obvious the tumor was progressing. And this child has done really well. We have complete control over the tumor. This child was enucleated right away because it had had many, many, many treatments before and indeed had some high-risk pathology, which the child's gone through chemotherapy for. But of all the complete remissions, we have had some recurrences later and more. This is the weeks from week 0. So you can see that in the cohort 2, we haven't got to that time of the 60, so we could still have more recurrences. But you can see, looking at this, it's hard to sort of see what's really happening here. So I'll go on to this view of all the study patients. And here's 0 to 16 when this was done in August. Now there's 17. And this is the work of Isabella Yanusovic, who was a summer student with me as an undergraduate, then as a graduate, and now as a second-year medical student. And last summer came back for her last summer off. And she figured out how to take our data from eCancer Care and put it in through Excel. She built this swimmer plot in Excel. And what this is each patient is followed up to here. So you can see that participant 1 has now been followed for almost 60 weeks and has had no recurrence. So all these symbols are drawn by Excel and put in automatically from the date of the event and the kind of event. So the diamonds are focal therapy, lumping laser and cryotherapy together. This is intraarterial chemo, etc. The purple here is the chemoplaque, the duration of the chemoplaque. And the blue line shows the time of removal. So this was in a report that FDA saw, who's watching this trial through 3T ophthalmics. And they said, oh, we don't want to talk too much until you have a comparative group. So Isabella went to eCancer Care and pulled out patients that were in eCancer Care with all the details, all the dates, everything there, quite easy to access them because we'd done this from the OR as we went along. But we only went not from 2003, but 2015, because then they would be comparable to treatments like intraarterial chemo that were more modern, more in time with today. And she picked matched patients who had received standard eye salvage care, which would be these 3 treatments. And this is the study participants for their old cancer staging, not the TNM, because that wasn't in use, and isn't in use in the eCancer Care RB. So A is tiny tumors and E is ones that should be enucleated. We have 1 participant in the study who's technically an E, but not really an E, and has had complete response. And then we matched the sort of the numbers of them as much as we could find them. And then this is the data from the matched summer plot of the matched eyes from all these patients pulled from eCancer Care. And the line is the, actually it's not the initial, it's the end of standard of care is the 0 point for these patients. So they've received all the cares they would, with all of them getting lots of chemo, et cetera. And then all the follow-up visits and all the things that they've had subsequently. So remember, I have the first patient is reaching about coming close to 60 weeks. So we can look here and go back to what some of them are only at 30 weeks. And you can see they've had much more treatment than any of the STEP RB eyes. So here, the gray line is the follow-up period, but with no treatments and no treatments and no treatments for these earlier follow-up ones. So I'm quite excited about this use of the data straight from eCancer Care. And in the future, that will come straight from Depict Health for any children that are on any care anywhere in the world, or just in standard of care, can also view what's happening with them that way. So I'll jump back to a couple of patients on the clinical trial, and I have to move Valerie here. There, 51 weeks is the follow-up for this patient, who, this is his eCancer Care timeline, which we didn't see him until he was about to lose his last eye, which you note is a group A eye at diagnosis. That eye should never need to be enucleated. But he's had many, many, many treatments starting back in 2014, and after 6 cycles of chemotherapy, his D eye, his right eye, was enucleated. If we'd known all of this, maybe it would have been the best eye with standard treatments. But they kept trying to treat this. We're missing a gap here because he went somewhere else, and we don't have any data on that period. So this is all the period we know about, and he was poised for enucleation when he came to Toronto on week 0. And amazingly, he's from the States, and very unusually, a wonderful person in Medicare undertook that they should cover this experimental use out of the country. And they had to take it beyond their standard rules up to the highest levels, and they've completely covered his time in Toronto for the chemoplaque, including his last visit, which was just a short time ago at 51 weeks. This is what he looked like when we first saw him. All the yellow arrows point to active retinoblastoma, which we can see looking through the indirect ophthalmoscope, all those. The lines here are optical coherence tomography with the handheld bioptogen instrument, which is only one of 2 I know in Canada, and very hard to get this image. And you can see that's the active tumor. So the yellow line corresponds to this OCT, etc. So we could see all these active tumors. We could also see his fovea, which is right where the X is, which has some serous fluid underneath it. And this is his retinal drawing from eCancer Care, with the yellow indicating the problems and a technically normal fovea. The green is where we put the chemoplaque. We did not put it inferiorly in him because he didn't have much good retina left, and he had a big scar here, and that's where it was anyway. So we put it up there. Normally we put the chemoplaques here because they make a full thickness scar, and superior scotoma from inferior scars are irrelevant in daily life compared to superior scotomas, so which completely disable your ability to see what you're going to step on. So that's why that's an important placing issue. So this is his week 51 follow-up, and he has no yellow left, no active tumor anywhere, and all these OCTs demonstrate the areas that we could see in pre-op to have cancer, and they're all flat scars. And this is again the location of the chemo plaque. We had one dose-limiting toxicity in a little girl who was about to lose her eye, treated initially not in Toronto until she had a huge problem and got some bleeding. And so then they sent her to Toronto for us to see if there was anything could be done to save her only eye. The other eye had already been removed. And when we first saw her, we saw blood, but we didn't see active tumor. So we had her come back 3 weeks later, and then we could see, oh, this is active tumor changing from her first visit. So at week 0, this is the active tumor. All this is not active and has never changed. And this fluoresced very hot at week -1, fluorescing angiogram indicating it's active tumor right there. We put the chemo plaque in. Then we saw her, we see them every 2 weeks, and she had a little bit of vitritis, maybe a little increase in the cells in the vitreous, but we could see clearly, and we didn't treat that particularly. And then she became quite disabled with not eating, not wanting to talk, only wanting to sleep, needing to be held. And so they admitted her in Montreal thinking maybe she had brain tumor. She did not have brain tumor, but they couldn't tell that. So that became a dose-limiting toxicity because she was in hospital for more than 24 hours. And that's the definition of dose-limiting toxicity. But then just before week 6, she got better, started to get better, clearly was up and walking around and starting to see a little bit more, although she sees not very well. And so then they discharged her and they brought her to Toronto, and we did her first EUA, and we could see why she was so distressed, because she couldn't see because of this severe vitritis, which is a serious adverse event and became a dose-limiting toxicity. We treated her with triamcinolone acetate and topical steroid, and by week 7, the vitreous was clearing up with a bunch of haze here, blood on top of where the active tumor is. So even at week 9, we couldn't see the tumor location properly because of blood, but we could see that there was no fluorescent uptake by it. So we knew that the chemo plaque probably had worked, and this was all vitritis. So here she is now at week 31. It looks the same as this. Sorry, I thought I'd changed that date, but it looks exactly like this. And there was a little panic on our team about this remaining haze was the tumor until we recognized that's exactly where the chemo plaque was. And there's always bleeding and haze and edema around the location of the chemo plaque. So that's the explanation, and this has gotten less and less with time. I think maybe the date changed. Yeah, this is week 31, and it looks exactly like that now. She's now having 1 visit in Montreal under EUA, and she passed that completely. They thought it was perfect. They have to report that to us right away for the clinical trial, and the next visit will be back in Toronto, and we'll alternate with them seeing her remotely or in Toronto. Oh, I didn't say, anybody wants to ask a question or chat anytime, please. And I'm happy to stop, or I'll go back on the slides if there's questions that need me to point to things in the slides. Should have said that at the beginning instead of me just marching on so quickly. So this is step RB 15, who got the 0.9 dose, was in for 40 days. And she was the first primary, no previous treatment to this patient. And that is because she was 2 months old when she was first diagnosed. She should have been diagnosed like the genetic offspring of H1 persons at -4 weeks age, at 36 weeks gestation, which is early term, not premature. But she was not because of messes up. And this is one of the COVID failures in timing, and many things got missed and went wrong here, but the outcome is okay. So here she was at week 0 at 2 months of age. To treat that eye needs chemotherapy for sure. can't treat that with focal therapy. So she could have had intraarterial chemotherapy, but she was very, very small, and it's not ideal to put a catheter through the femoral artery into the ophthalmic artery in a 2-month-old baby, and could have been treated with systemic chemo, but they don't even know how to dose them because they give them too little dose. And then we know from our own published experience that if you give them low dose, because they're so tiny, you end up with drug resistance. You're creating drug resistance just like you would with the tumor cells in a petri dish by gradually increasing the dose of the drug, letting them become more resistant, sort of like COVID becomes more infectious. Yeah. So we put her on the chemo plaque. This is actually an ultrasound showing the chemo plaque in place. You can see how big it is relevant to the eye. But this is the shadow, not of tumor, but this is of the chemo plaque. It happens to get the corner of the implant by the way we angled the ultrasound to get that, but the chemo plaque was not right under it. So at week 6, she already had a tremendous response from this, and even recovery of some fovea, some normal retina between the optic nerve and the calcium. She did have a little bubble top of this, right on top of this dome of calcium, and vitreous going out beyond it. But now, and she's at week 25, you can see a very large chemoplaque scar, very complete, and more extension of scar here, which probably represents the retinal detachment that was here. So we called this a group C, or T21B, because of the retinal attachment. So this here isn't chemoplaque, but it might be an increased drug that might have diffused from the chemoplaque after it enters the eye because it was under the retina. So we'll only learn those sort of things as we go along. But superiorly, she has completely normal retina, and she is developing preferred looking, which might even be using this little piece of retina here. Only when she's much older will we know exactly what she's using. But superiorly, she has normal retina. We will patch her other eye to force this to develop. And this will protect her from tripping over things because she will have her absolute blind spot. All of this will be superior scotoma. So we don't always succeed, and we've had late recurrence, 61 weeks in our patient 2, participant 2. We don't call them patients on the study, they're participants because they volunteer for this device. And there's the target, calcium, when we treated it with the chemoplaque and coming out of calcium. And here it looked good until week 51, where target 1, he had another little thing that wasn't really a target, I don't think, but it was an inactive tumor, but we had to call it target 2, but we'll only talk about this. And that's where 1 chemoplaque was placed. He's been on 2 chemoplaques. His first was part of the special access program, and this is the 2nd chemoplaque. And but no severe uveitis in that child, and then a recurrence at week 61, exactly where this was. So the most unresponsive kind of tumor is buried in calcium. And I'll comment more how we need more for that. So this I'd been through a lot, although he had a fovea, it wasn't very functional. He wasn't really using that eye, and we didn't know what next to do, and there's danger that we can't laser on top of calcium. We don't know what's happening to choroid, so we removed his eye with lots of consent that it's time to stop fiddling around, and he's doing really, really well with a beautiful artificial eye, and the pathology showed no high risk, so we took it out in time.
Brenda, there is a question from Valerie.
Yes.
The question is, why or how does the plaque induce a scar, and does it kill non-tumor cells?
Yes, so it induces a scar like this. What we see, I don't have pictures here, but as soon as we put it in, we see edema of the retina, a little hemorrhage over retina and choroid, and a little hemorrhage over it. And then that gradually goes away, and ultimately we're left with an absolute full thickness scar right down to sclera. And on OCT, there is no think on another one. No, maybe I don't know. Sorry, I'm going the wrong way. I want to go backwards. I don't have, oh, right here. Here's where his chemoplaque scar is, and there's a little bit of blood there.
So that's killing the retina, right?
Kills
From-
the retina on opposite the chemoplaque, because the chemoplaque sits with the drug directly on sclera. And the sclera diffuses right through the flange, is shaped to the curve of the eye. We don't glue it on the eye completely, only to keep it with one point.
Right.
But it is hugging the eye, and none of the drug goes under the conjunctiva, although now at this dose, we are doing PK studies, and we've done the first patient, we've done PK studies, but we hadn't done PK studies before that. But they have no indication that there's any systemic exposure. So all the drug in here is going into the eye, and it's diffusing through sclera, choroid, and retina. And it kills those cells, yes.
So it kills those cells because they just see a high dose of it because it's going into that, it's diffusing just right there.
That's correct. And I'll come to it in just a minute. But maybe.
We have another question from David. David, you can unmute yourself and ask your question, please.
Hi, I was wondering what is the incidence of vitritis in these patients who undergo plaque therapy? And do you get a steroid response with triamcinolone treatment? Because that's usually common.
Yes, I'll go back to this patient. This is the most severe we've seen, but the very last patient on the study, who I may not have here, they all have some degree of vitritis. It's very mild. In our protocol version 5, we now are treating, and we're at higher doses now too, all of them with topical steroid with Predfort starting at week 2, and not waiting till they show signs of vitritis. We don't use triamcinolone acetate unless it's more severe. And that's not what we can, and we only used it in one patient so far. We now know that it's not vitritis that's the primary problem. The children all become irritable. The parents say it's like they're teething. Oh, maybe they're just teething, is what they always say. And it's because they stop eating so regularly. They wake up in the night. They want to be held more. They're photophobic, which would point to vitritis. And as soon as the chemoplaque starts to run out of drug, they start to get better. And when we take it out, they're all better. But we now realize it's scleritis. And we thought that would, because their signs would be consistent with the sort of deep, non-specific pain of scleritis, as opposed to vitritis. And so the last patient, who was the first one, I don't think I included pictures of him here. No, I didn't. But he's, I'll jump way back to here. He is participant 17. He's a primary group D, huge tumor in the eye, touching the lens, but we didn't see it invading the anterior segment of the eye on all our imaging. He had he's not got a complete remission. He's got a partial remission. Why is that there? That's incorrect. He's had a partial remission, but the tumor never separated from the lens and the anterior segment of the eye. And so at week 9, we enucleated because there was no potential for useful vision in the eye, although he did have approximately 20% regression in the size of the tumor. So we have pathology on a week 9 eye. That's very, very important. And it shows, because this is too recent, and the pathology for sick kids for retinoblastoma eyes is done in Calgary, where the best eye pathologist in Canada is now at Alberta Children's Hospital. I first met her when she was in Birmingham, England, doing all the retinoblastoma pathology. And then I discovered where she was when I enucleated an eye in Calgary. And now she's doing it all for us. And I looked at when I was in Calgary a week ago down the microscope with her, but I don't have pictures from her. showing absolutely scleritis and necrotic scleral fibers in the sclera at week 9. We think that recovers. There's no thinness of sclera that we observe on any of our imaging in the other eyes. But because of that, we will put all of them on at least topical steroid. And that's one of the reasons I think we may not get to cohort 3, because I think we may find this actually truly becomes dose limiting. And as long as our efficacy is substantial, so that most of our treatments for complete remission are focal, and we succeed, as you can see here, we're succeeding with focal therapy. It really is, we don't need to go to a higher dose. And I'll jump further here. So the next steps in the study are continuing to finish cohort 3 and maybe go to cohort 4 or not. But I think we should stop here and instead go to new drugs, new anti-cancer drugs in the chemoplaque. The chemoplaque has also been used, the plaque has also been used by 3T ophthalmics for steroid deployment in eyes with severe chronic inflammatory disease. It's totally dependent on steroid with all the problems of glaucoma and everything else. And exposure for a year through the chemoplaque of a steady dose resulted in no steroid response in eye pressure and really beautiful remission. But then they took it out after a year because that was the study, and the patients reverted. So there may well be very exciting novel therapies coming that are on the brink, that have emerged actually from genomic studies and prediction of what drugs should work in retinoblastoma that are too toxic for systemic use, and put those in the chemoplaque would be really exciting. But pertinent to all of you, the chemoplaque therapy, likely steroid, could be a therapy for other eye diseases, including maybe even glaucoma, where the participants would not be exposed to pulses of steroid, pulses of anti-glaucoma therapy when they remember to put their drops in, but have steady exposure without needing to add drops. So it's got huge potential to go in many directions, I think. We're the first ones in the world to ever use this little silicone device. So I'm just going to jump to my last point, and that's the patient partnership. Did I answer all your questions?
Yes, sorry, there is another question from Tahani. Tahani, you can unmute yourself.
Okay, so I have one question regarding the chemoplaque. Is it possible to insert in kids with bilateral retinoblastoma to insert it at the same time? Like you put 2 chemoplaques at the same time, or does the clinical trial only included those with unilateral retinoblastoma cases?
I'll answer your last point first. We can clearly put it on unilateral or bilateral patients, but in this trial, we cannot, STEP-RB trial, we cannot put it 2 in the same time. We can treat one eye on the study, and we can treat the other eye on the study separately as separate entries into the study, but not 2 at the same time. That doesn't mean that once the study's finished, we couldn't put it in, do it.
And the outcome is similar in both cases?
We haven't put it in 2 eyes, but we have put it, I don't think we treated any child with chemoplaque in 2 eyes yet.
Okay.
In the second eye. But an eye is an eye, and I think I would expect the response to be similar. Yeah.
And I have other question. And those with relapses, do you insert another chemoplaque to those kids, or just put them on other treatment methods?
When they fail after the chemoplaque, we do all sorts of other things, and then we might still put in another chemoplaque. And participant 2 had 2 chemoplaques. They were about a year apart. Yeah,
I see. Thank you.
So I'd just like to talk about these partnerships, the patient partnerships in research, which is really, really exciting initiative of Helen Damaris, who has really brought this forward. We've always included parents, and we've always wanted in Depict Health, we wanted the parents to view their own whole record as it happens. They ask for pictures all the time. And the ones that you will find when you go to the Depict Health View have volunteered, they've made up a false name for their kid, etc. But the data is real and they want us to fill it out all the time. But Helen Damaris did her PhD in my lab in molecular genetics of retinoblastoma. And she's the person who really defined the post-RB1 transitions to full malignancy through the other genes that become altered in the RB minus cells. And that is by her work in retinoma and other studies she did at that time. And she has always been interested in people, patients, and participation. And she leads the Canadian Retinoblastoma Research Advisory Board. I think she leads it, but the people who are also on this top 10 research priorities paper published are Caitlin Flegg, who is the coordinator for the whole retinoblastoma research program at Sick Kids, but on maternity leave right now. And Max, who started this, joining the advisory board as an undergraduate, and then as a medical student, and now a resident in the Toronto Western Hospital in ophthalmology. Sarah Johnson, I have to particularly honor and thank for her tremendous work. She had bilateral retinoblastoma. I treated her as a child. She went on to become a neuroscientist and had just got her first job. A lot of her postdoc work was in Florida, then her first job in the University of Chicago. And when she became very ill with her second cancer and died. So the fund in her honor is called Sarah Looks Forward. And that's what we need to do to look forward to solve these top 10 research priorities in Canada. And go to the next slide. This is the top 10 research priorities published in a beautiful, beautiful paper on how to develop research priorities with full participation of all parents and people, all sorts of people involved in the disease. And you can see second cancers hits 3 of the top 10 priorities for research priorities. But we haven't actually, since this was published, which is 2020, we have not done anything there. It's not moved forward. The initial thought, and actually Stephanie Kletke, who I mentioned, who's now on staff, one of her first projects as a resident in retinoblastoma was to develop a protocol for whole body MRI to follow these patients for the rest of their life to find their cancer that is in danger of killing them before they die, before they show signs and symptoms, and then are untreatable. But that's very costly, very ineffective, and we never got that launched, even though it is done for Lee patients with great leadership from Villani and Malkin at Sick Kids in that cancer. But the new things have emerged that are really, really exciting in retinoblastoma, and that will be the use of, here, I'll go into it here. I'll go first to this last patient who illustrates the problem here. This is a little baby who was the offspring of a family with a lot of retinoblastoma. So her father had retinoblastoma, like his 3 siblings. All the red are retinoblastoma. And so all of the people in red are H1 because they carry the retinoblastoma gene in their germline. And her father, the first child, did not carry it, so he was a true H0. The mother is alive and well, who was treated many years ago. I think she's in her late 70s, maybe she's 80, by bilateral enucleation, great treatment for retinoblastoma. But all 4 of her children were irradiated. I was involved in the treatment of all of them. And 2 of them have died of their second cancer. So her father is in danger of a second cancer. And so from that point, we no longer use radiation at all due to the brilliant work in chemotherapy that Helen Damaris developed, and was the study that Helen Damaris didn't develop the chemotherapy. Helen Chan developed the chemotherapy and then was in the early 90s, and that's what now has really removed external beam radiation from treatment of retinoblastoma. And Helen Damaris and Helen Chan together did the international study of a novel approach to that, which is not yet published. But this baby was diagnosed and delivered at 36 weeks gestation, because we knew from her prenatal amniocentesis that she carried the mutation. And here is the tumor at week 1. No, this is we first treated these tiny tumors with laser because they didn't need a chemo plaque at that time. But when these were not responding well enough to laser, and here's a seed, a vitreous seed with a hollow center because it's dead inside the vitreous seed, and another seed about to launch out of here. If we'd lasered those again, those would have been complete vitreous seeding everywhere. So at that point, we said it's time to put in a chemo plaque. And we put the chemo plaque in. Here she is now at week 28 with her very large, because she's only, I can't think how old she was exactly at this time, but very small eye still, under 6 months. And here's her scar right there. This is a little edge of the scar. This is where the chemo plaque was. So you can see, Valerie, there's sclera. We don't see the scleritis here in the final scar, but I don't know that we've ever looked like that. Particularly, we don't see well into that. And here's no choroid, no retina under the scar right here. But all of her tumors have responded beautifully. She has a normal fovea, perfect fovea, and we're now in follow-up at 28 weeks. She still could have a recurrence anywhere, or a new tumor in this susceptible H1 eye. But we keep watching her very closely, and we'll treat those with focal therapy as they emerge. So retinoblastoma is complex. The point of care, very RB specific Health Canada Depict Health database, which its model could be developed for other kinds of cancer, other kinds of diseases that have a lifelong chronic issues. But the patients who finish their focal therapy for their eye will still be in Depict Health for the rest of their life. And indeed, their appointments for their follow-up blood tests will be there. And that will be for looking for cell-free tumor DNA in plasma to dissect nascent cancers. And that's a new research initiative that Stephanie Klepke and Helen Damaris put together as a research grant, but I think they were being scooped by the group in New York, who have shown with a now licensed New York State test for cell-free tumor DNA in serum for all cancers. And that's going to be the way to go. So their annual appointments to look at their DNA that might show a cancer in these patients will be in their Depict Health record. So it includes families in the circle of care. It brings them right into the following of the doctors aren't making their own decisions. The patients are saying, wait a minute, you didn't show me what you told me about afterwards. Show me the picture. Why isn't it in Depict Health now? It supports efficacy in the clinical trial because it will feed data into the clinical trial and go global so that we'll be able to collect data from all over the world. In fact, Depict Health caught the attention of the Pediatric Cancer Data Commons, which didn't have retinoblastoma in it. And now the database in this commons, which collects data from pediatric cancers, mostly around the US, but now going very much global, will be feeding through from Depict Health when the patient is in Depict Health or in a clinical trial, will be the data set going straight out. So in Depict Health, we have 2 consents. The first consent is to use it in all of these points for, or mainly including family in the circle of care, and in clinical care. The second consent is for research use of consented coded aggregate data. And that data we don't have to, we built this whole tool, modeled it all out, but we may not have to do all that work because the Pediatric Data Commons will do that deployment of the data we collect to any other valuable study that comes from the world, and they can vet the studies for us. Precision care is achieved by prenatal genetics for these H1 babies. I showed you a few of them. And optical coherence tomography, I show how totally critical it is, and we need more, we need the bioptogen to be even better, and not something you have to hold the baby up to, but a real handheld tool. And STEP RB clinical trial and the research advisory board, which is very, very exciting, for pointing us strongly, the patients with lived experience, pushing us to the top priorities for them. Thank you very much.
All right, thank you very much, Brenda, for this fantastic talk. We already have a few questions here, so I will ask James to unmute and ask his question.
Hi, Brenda. Thanks for an excellent talk there. It was very interesting. I just had a question about the Depict Health and your clinical trial there. The kind of database controls that you used, are they common in critical trials now, or sorry, in clinical trials now? And do you see them as kind of the future for small clinical trials moving forward? It seems like a very powerful tool.
Well, I haven't seen it anywhere else like this. No, swimmer's plots are used, but they're often more static sort of things, I think. So I haven't seen that, but I have, in our protocol, when we developed it, it occurred to me that in follow-up, we call it complete remission based on the standard kind of percentage of change in size of the tumor, which is really hard to evaluate for retinoblastoma because there's a whole bunch of different tumors. How do you lump those together? So we don't get those kind of measurements. And I said, how are we going to know when what the success is? So our follow-up is to score any other treatment to that eye. And so if a patient needs systemic chemotherapy for that eye, if they need it for the other eye, that doesn't count. But if they need it for that eye, or anytime we do focal therapy, those count. And that's where you get to this data. So the clinical trial was collecting this data, was planned like this, but it really was Isabella and eCancer Care RB and our love of timelines that let us build this. And Isabella made it in beautiful Excel file, but I have trouble to update it. So you see, I haven't got the last patient in here because I have trouble doing that. It's complex. She can do it perfectly, but unfortunately she's back in medical school. She's a second-year medical school at U of T, and she hasn't got time to do this. So I have another very good fellow from PMH Ocular Oncology who's from Brazil, and he's going to make an attempt, he thinks he can, to turn this into an app based on this, so that then all you really need to do is put in the date and the event, and it will redraw the drawing. So that's what I need it to turn into. But this is all ours. I don't know that anybody has used need to treat as a criteria for failure in a clinical trial. So the swimmer plot basically shows another way to look at it would be time to failure. But there's more information in here than time to failure, because intraarterial chemotherapy, jump to here, is an invasive treatment. That's a big treatment, whereas laser is not. So we really need to grade the severity of the treatment that was needed to capture the final conclusion. Does that answer your question?
Oh, definitely. It seems like a very powerful tool, and it's I think it should be kind of the model for recording this kind of information moving forward across the board. It's very interesting. Thank you.
Thank you very much. So anyone who knows how to make little apps and wants a little project, I'll give you the Excel and you can help me out in keeping the
I would actually love that information. I might get your contact your information after the talk here. Thanks again.
Good. My email is really easy. It's brenda@gallie.ca. I'd love to hear from you, James. That's great.
I don't see other questions for now. I have a question. I don't know if this exists. Maybe it's a naive question, but is there some sort of comprehensive approach that would include visual rehab also for those patients?
Oh, yes. Sorry, I'm trying to get out of here. Yeah. Okay. Visual rehab is really interesting. I still got you? Yes. Okay. And visual rehab involves when the normal eye or the eye with normal vision is taking over and it does all the work. And the eye we've saved with 20, actually.
Oh, we can't hear you anymore, Brenda.
That's weird.
Did you cover the microphone of your computer or something like this?
No.
There we go. It's
You're
okay.
back. You're back.
Okay, good. I was pointing to, can you see this? Can you see my slide here?
We have a large table. Yeah.
A swimmer plot.
Yes.
Oh, so I want to go to this one. Let me go back here. There's a bit of a lag there. They should come to the slide I'm looking at. Maybe, yes. This slide?
Yes.
Yep.
No? Okay, so this, I'll jump forward in it. When he was diagnosed, he has a fovea, but it's sitting in here. He had actually retinal detachment, and it variably as things progressed or changed in this eye, poor vision. He only has one eye because we took the other out. So this is his only eye. And that eye didn't need to have the other eye patched. It was already there. I'm just going to somehow get rid of my husband calling me here. Okay. Because he didn't have another eye. But this is now giving 20/50 vision, which is incredibly good vision. He had been way less than that throughout all these different treatments and different retinal detachment. But you can see his retina is not normal at all around here. So of course it's going to be, oh, my computer's going to run out of power. Okay, we won't worry about that for a minute. He has gained vision because he has to use it. So the other kids that have another eye that's better vision, we patch that eye and we force them to use the bad eye. Okay.
Okay. Yeah. Thank you. Valerie has a question also.
Yeah, I was intrigued by some of those images, Brenda, where you showed a lot of vessels invading the tumors.
Yep.
So is there anything known about the, how tumors are co-opting vessels in that context? And is there anything, would there be value in trying to block that angiogenesis to the tumors?
Yes, there certainly would be. There have been maybe some attempts in that direction, but it has not sorry, got to stand up because I've got cramp in my leg. I don't think not much has happened there. You would think that would be good. And the timing for that, the timing for a treatment like that would be very early.
Yeah.
So that might be something you might someday put in a chemoplaque.
Yeah. Yeah.
Because you want to stop that angiogenesis before the tumor starts really growing, not when it's a big ugly one like these.
Yeah.
But that's an excellent idea. So I would love somebody to think about that. Yeah. And an anti-angiogenesis chemoplaque might be useful for other things like retinopathy of prematurity or other eye diseases with vascularization taking over. I don't know.
Mhm. Definitely
Okay.
food for thought.
We don't have any more questions for now. So